Describe your experience with pain and symptom management in palliative care, including the use of comfort kits.
My experience in pain and symptom management has been extensive, particularly during my 3 years working on a dedicated home hospice team where the goal was always anticipatory, rather than reactive, comfort. I have developed a strong competency in titrating opioids and other adjuvant medications to achieve optimal pain control while mitigating common side effects like constipation or nausea. I regularly utilize the WHO pain ladder principles, moving beyond oral routes to subcutaneous or transdermal patches when swallowing becomes difficult or absorption is inconsistent, always ensuring a consistent, steady level of analgesia. A prime example of this proactive approach involves the use of comfort kits. In one instance, a patient with advanced lung cancer at home began experiencing periods of increasing anxiety and restlessness late one evening, which escalated to mild air hunger. The situation required immediate action to prevent distress. My task was to rapidly stabilize her symptoms and educate the family. I acted immediately by instructing the primary caregiver to administer the prescribed low-dose oral morphine and a small dose of lorazepam from the comfort kit. Crucially, I maintained verbal contact until the dose took effect, providing calming assurance to both the patient and the distressed family. The result was rapid relief of both the dyspnea and anxiety, allowing the patient to rest comfortably without requiring an emergent hospital transfer. Beyond pain, I effectively manage other complex symptoms like refractory nausea, bowel obstruction symptoms, and terminal restlessness, often employing non-pharmacological interventions such as essential oils, repositioning, and therapeutic communication to supplement medication. My philosophy is to anticipate distress before it even manifests, relying on frequent, thorough assessments and the appropriate, safe use of those critical comfort medications.
How do you manage dyspnea in a non-invasive way for a patient nearing the end of life?
Addressing dyspnea non-invasively is a cornerstone of excellent palliative care, focusing entirely on comfort and perception of breathlessness rather than just mechanical intervention. I recently managed a situation with a hospice patient diagnosed with severe pulmonary fibrosis who experienced frequent, distressing episodes of dyspnea, particularly during movement or when lying flat. His anxiety exacerbated his shortness of breath, creating a fearful cycle. The family insisted he could not tolerate or did not need high-flow oxygen, making non-invasive strategies crucial. My task was to break the anxiety-dyspnea cycle by employing a range of pharmacological and non-pharmacological, non-invasive interventions to restore comfort, reduce the patient's perception of breathlessness, and empower the family to safely support him at home. My actions started with positioning and environmental control. I immediately optimized his position using the tripod position, leaning forward slightly with arms supported, which facilitates better chest expansion. I ensured the room was cool, well-ventilated, and used a small handheld fan directed toward his face. This simple, non-invasive intervention triggers the trigeminal nerve, creating a sensation of coolness that significantly reduces the perception of air hunger. Pharmacologically, I administered a low standing dose of oral morphine, a highly effective non-invasive treatment for breathlessness, independent of its analgesic effects, to reduce the respiratory drive and lessen anxiety. I also taught the patient and family simple pursed lip breathing techniques to control exhalation. The result was a rapid, visible decrease in the patient's respiratory rate and overall distress. By using the fan and the morphine synergistically, we successfully managed his dyspnea without recourse to invasive ventilation or high-flow oxygen, demonstrating that effective non-invasive care is often the most humane and efficient way to uphold a patient's comfort goals in the end-of-life setting.
What are the signs and symptoms of imminent death you look for, and how do you communicate these changes to the family?
Recognizing and accurately interpreting the signs of imminent death is perhaps the most profound responsibility of a hospice nurse, as it allows the patient and family to prepare for the final moments. Clinically, I look for a cluster of physical changes that signal the body's physiological shutdown. These include alterations in consciousness, where the patient becomes unresponsive or only briefly rousable, often coupled with a characteristic change in breathing patterns, such as Cheyne-Stokes respiration, a cyclical pattern of waxing and waning deep breaths followed by periods of apnea. The skin often changes dramatically, becoming mottled or cyanotic, especially in the extremities, indicating decreased peripheral circulation. Other key signs are terminal restlessness, a significant decrease in urine output, and a loss of the ability to swallow, leading to gurgling respirations known as the death rattle. The way I communicate these changes to the family must be done with immense compassion and direct clarity. I use simple, non-medical language and a very calm, gentle tone. My communication follows a clear structure. I first validate their observations, for example. I see you've noticed their breathing is different now. Then I normalize the change by explaining the physiological mechanism, stating their body is naturally beginning to slow down, and these deeper pauses are a common part of this final transition. I never use euphemisms like passing on, but rather gently state, the time for them to die is now very near. We are moving into the final hours or perhaps minutes. I always emphasize that these changes are natural and that the patient is usually no longer experiencing pain in the way they once did. My primary goal is to shift the family's focus from worry to presence, encouraging them to hold hands, talk, and just be present with their loved one, which is the greatest comfort they can provide in those final moments. This compassionate honesty provides essential permission for the family to grieve and say their goodbyes.
Can you explain the difference between palliative care and hospice care?
That is a fundamental question, and understanding the distinction between palliative care and hospice care is crucial for directing patients to the appropriate services at the right time. While both models focus on maximizing comfort and quality of life, the key difference lies in timing and prognosis. Palliative care is an approach that provides relief from the symptoms and stress of a serious illness, regardless of the diagnosis or prognosis. Crucially, palliative care can be initiated at any stage of a serious illness. It can start right at diagnosis and can be provided concurrently with curative or life-prolonging treatments. The goal is to improve the patient's and family's quality of life by managing pain, controlling symptoms, and addressing psychological and spiritual needs. For example, a patient undergoing chemotherapy for cancer or managing advanced heart failure could simultaneously receive palliative care services to manage nausea or anxiety while they actively pursue a cure or life-extending treatment. In contrast, hospice care is a specific type of palliative care provided when a patient has made the decision to stop treatment aimed at curing the underlying disease. To qualify for hospice, a patient must meet strict eligibility criteria, specifically having a prognosis of 6 months or less if the disease runs its expected course, is certified by 2 physicians. Hospice is focused purely on comfort and support during the final phase of life. Therefore, it does not include curative treatment. It is a holistic, interdisciplinary model provided typically in the patient's home, aiming to make their remaining time as peaceful and dignified as possible. In essence, all hospice care is palliative care, but not all palliative care is hospice care.
A patient is asking to stop all food and hydration. How do you respond? And what are the ethical considerations?
When a patient requests to stop all food and hydration, this is a profoundly significant request that must be approached with the utmost sensitivity, respect, and a deep understanding of ethical principles within palliative care. My immediate response will be non-judgmental and supportive. I would first sit down with the patient to acknowledge their feelings and ensure they are making this request autonomously and fully informed. I would use therapeutic listening to understand the motivation behind a request. Is it due to discomfort, fear, a desire to hasten death, or a natural loss of appetite associated with a dying process? It is crucial to distinguish between a patient choosing to forego life-prolonging intervention, which stopping artificial nutrition and hydration is considered, and a desire for physician-assisted suicide, which is a key ethical boundary. The ethical considerations are primarily centered on patient autonomy and beneficence. The principle of autonomy affirms the patient's right to refuse medical intervention, even if that intervention is food and water. For a terminally ill patient, artificial hydration and nutrition are considered medical treatments, and they have the legal and ethical right to decline them. Furthermore, attempting to force feeding or hydration against their will violates their dignity and often increases discomfort, such as fluid overload or aspiration risk. The principle of beneficence shifts from prolonging life to maximizing comfort. Studies show that stopping hydration often does not increase suffering in the final days and may actually decrease uncomfortable symptoms like swelling or the need for frequent urination. To address the situation where a patient explicitly asks for this, my task is to facilitate a meeting with the interdisciplinary team, the physician, social worker, and chaplain. I would act by ensuring the entire team discusses the full implications, confirms the patient's decisional capacity, and verifies that all comfort measures, especially mouth and skin care, are maximized. The result is a decision that honors the patient's wishes while upholding professional and ethical obligations, ensuring a dignified death.
How do you manage a family member who is struggling to accept the terminal diagnosis and demands aggressive, futile treatment?
Handling conflict driven by grief and denial is one of the most challenging aspects of hospice care, demanding ethical clarity and compassionate communication. I encountered a sensitive situation with a patient suffering from end-stage heart failure. The patient had clearly articulated goals for comfort-focused care and had signed a do not resuscitate DNR order. However, his eldest daughter, who lived remotely, arrived and was in complete denial, strongly demanding aggressive, heroic interventions like a permanent ventricular assist device, VAD, contradicting the patient's wishes and current palliative care plan. My task was twofold. First, to firmly uphold the patient's articulated wishes and the existing goals of care, and second, to gently validate the daughter's fear and distress, helping her transition from a curing mindset to a comforting mindset without engaging in an argument about futility. My action was to facilitate a dedicated family meeting involving the hospice physician and social worker. I did not focus on the technical futility of the VAD. Instead, I used therapeutic communication to shift the focus back to the patient's narrative and quality of life. I asked the daughter, "Tell me what a good day looks like for your father right now." I used her response to pivot, explaining that the aggressive intervention she wanted would require him to be sedated, tethered to machines, and unable to interact, which was contrary to his documented wish to be conscious and present with his family. I framed the palliative plan as the most loving and respectful action. The result was not immediate acceptance, but a crucial shift toward understanding. By validating her love and grief while respectfully centering the conversation on her father's documented values, the daughter eventually agreed to pause her demands. She focused her energy on maximizing his comfort and final moments, respecting the existing DNR status and the care plan that prioritized his dignity and peace.
How do you ensure the patient's dignity and autonomy are maintained, even when they can no longer communicate their wishes?
Ensuring a patient's dignity and autonomy is paramount in hospice care, especially when their ability to communicate is compromised. Since their wishes can no longer be voiced, we rely heavily on advanced planning and nonverbal actions to uphold their intrinsic worth. My initial step is always to review their advance directives, including any living wills and the most recent goals of care documentation. This written record serves as their voice, guiding all care decisions, such as whether to administer antibiotics for a terminal infection or whether to pursue minor invasive procedures. By strictly adhering to these documented preferences, we honor their autonomy even in silence. However, dignity extends beyond legal documentation. It is maintained through meticulous physical care. I ensure that all physical tasks are carried out with the utmost respect. For instance, before performing any hygiene task or brief medical intervention, even when the patient is unconscious, I still address them directly, saying something like, "Mr. Smith, I'm just going to turn you gently now to make sure you are comfortable," or "I'm going to give you a sip of water now." This simple act respects the personhood of the patient. I ensure their privacy is maintained at all times by closing doors and curtains, covering them appropriately, and maintaining modesty, particularly during personal care. A crucial aspect is maintaining their appearance. I advocate for daily oral care, shaving for male patients, and light cosmetic care if the family requests it, as these small actions convey that the patient is still valued and respected. I also ensure the family is fully involved in non-medical decisions, such as music selection or room lighting, giving them a role in maintaining the patient's comfortable environment. All these actions together demonstrate that their life and comfort remain our professional focus until the very end.
Tell me about a time when you had to deal with a difficult death or a complicated grief situation.
Dealing with a difficult death or a complicated grief situation requires immense emotional resilience and the ability to maintain professional boundaries while offering deep compassion. I recall a specific situation involving a young patient in their late 30s who had terminal cancer. She had a 5-year-old child and a very supportive but completely overwhelmed husband. Her death itself was not difficult clinically, but the anticipated and actual grief of the husband was profound and quickly became complicated. My task was to support the husband through the active dying phase and the immediate hours after death, ensuring he could say goodbye and transition into the next stage without completely breaking down. I acted by recognizing that his primary need was to feel empowered and connected, not just comforted. During the final hours, instead of merely standing by, I involved him in very simple, concrete tasks, wetting his wife's lips with a swab, holding her hand, and speaking to her. I maintained a calm, steady presence, answering his repeated questions about her breathing and signs of death with clear, simple, and honest language. Crucially, immediately after she passed, he became hysterical. I gently guided him to step out for a few minutes, giving him a quiet space to process the shock before returning. I then offered him the opportunity to bathe and dress his wife, which he initially refused but later decided to do with my assistance. The result of this focused, gentle involvement was that he managed to move through the acute shock without needing sedation, and he later expressed that the act of caring for her one last time provided him with the foundation he needed to begin his journey through grief. It reinforced my belief that structured involvement is key to navigating complicated grief.
Describe your experience working with an interdisciplinary team.
Working within a truly interdisciplinary team is not just preferred in hospice care. It is mandatory for comprehensive, holistic patient support. A complex situation arose with one of my patients who was physically comfortable but exhibiting significant anticipatory grief and withdrawal. His primary pain was existential, rooted in a strained relationship with his estranged son. This was impacting his spiritual peace and willingness to accept oral medications, which was a barrier I could not address alone. My task was to recognize that the core issue was non-clinical and required the expertise of our wider team. I needed to effectively collaborate with the social worker and the chaplain to address the psychological and spiritual distress, allowing me to focus on the patient's physical needs. My actions started with activating the team via a concise case briefing during our morning huddle, highlighting that the clinical risk was related to the psychosocial barrier. I specifically requested the social worker to take the lead on exploring options for reconciliation or mediated contact with the estranged son. They specialize in family dynamics and resource negotiation. Simultaneously, I asked the chaplain to visit, not to preach, but to offer spiritual presence and facilitate a conversation about life review and finding meaning, regardless of the son's presence. My role remained central, monitoring his physical comfort and anxiety levels, and providing feedback to the team regarding how their interventions were affecting his vital signs and compliance with medication. The result was a beautifully coordinated effort. While the son was unable to visit, the chaplain helped the patient articulate his feelings and record a video message, bringing him a huge sense of closure. The social worker then supported the family in securing legal documentation. This collaboration broke the cycle of emotional distress and physical refusal, allowing the patient to accept his medications and pass peacefully, demonstrating that a hospice nurse's greatest strength is their ability to effectively coordinate the diverse specialists needed to care for the whole person.
How do you facilitate a conversation with the patient and family about goals of care or completing an advance directive?
I believe that facilitating conversations around goals of care, GOC, and advanced directives, AD, is a critical nursing skill that requires a foundation of empathy and clear communication, always using a structured approach. I recently cared for a 78-year-old patient admitted with severe, worsening respiratory failure, necessitating high-flow oxygen. While the clinical team recognized the need to discuss options beyond aggressive intervention, the family was visibly anxious and avoiding the topic. My task was to compassionately initiate and guide a conversation with a patient and his adult children to ensure they fully understood his prognosis, clarify his personal values, and facilitate the completion of an advance directive that genuinely aligned with his wishes. To do this, I first secured a private, quiet room, ensuring a calm environment free of clinical distractions. I began by asking open-ended questions like, what is your understanding of what is happening now? And what are your greatest hopes for the next few months? This patient-first approach helped me frame the discussion around his quality of life and values, rather than immediately focusing on clinical procedures. I then introduced the advance directive not as an end-of-life document, but as an essential tool for empowerment, ensuring his voice would guide future decisions, even if he couldn't speak for himself. I carefully explained the difference between comfort care and life-prolonging treatments using simple, non-technical language. As a result of this sensitive, structured approach, The patient felt respected and in control, articulating a clear preference for comfort measures and identifying his substitute decision maker. We successfully completed the necessary GOC and AD documentation, which brought both the patient and the family immense peace of mind and allowed the care team to adjust his plan to truly reflect his articulated goals.
How do you handle a situation where a patient expresses fear, anger, or deep regret about their life?
I believe that handling a patient's intense emotional expression requires grounding, active listening, and a non-judgmental approach, which is crucial for holistic nursing care. I recall a situation where I was caring for a 55-year-old patient who had just received a life-altering diagnosis. While reviewing his medications, he suddenly became tearful, then angry, stating he felt he'd wasted his life and was deeply afraid of what was to come. His regret and fear were overwhelming him, causing him to lash out at the diagnosis and his perceived failures. My task was immediate: to de-escalate his emotional distress, validate his profound feelings of fear and regret, and re-establish a therapeutic connection so he could participate constructively in his care planning. My goal was not to fix his regrets, but to provide a safe space for him to express them. My action was to first stop what I was doing, pull up a chair, and ensure I was at eye level. I maintained a calm, open posture and used therapeutic communication techniques. I stated, "I can see this diagnosis has brought up many painful feelings, and it sounds like you're grappling with deep regret right now. I'm here to listen." This simple validation acknowledged his pain without minimizing it. I then gave him time and space to talk without interrupting. When he was ready, I gently guided the conversation back to the present, focusing on what we could control. I asked, "Given what you're feeling, what is one small thing we can do today to make you feel safer or more comfortable?" I then contacted the hospital's pastoral care team and the social worker to ensure he had resources for emotional and spiritual support beyond my shift. The result was that the patient's anger quickly dissipated as he felt truly heard. By validating his feelings and offering practical support, we transitioned from an emotional crisis to a therapeutic partnership. He agreed to meet with a counselor, and by the end of my shift, he was focused on his pain management and felt less isolated, allowing the care team to move forward with the necessary treatment plan.
What is your approach to educating family caregivers on medication administration and personal care?
Handling the transition from hospital to home care for a patient, particularly concerning medication and personal care, relies heavily on structured teach-back education. I recently dealt with a situation involving a patient being discharged after a cardiac event who required a complex medication regimen, including a new anticoagulant, and needed assistance with daily hygiene due to mobility issues. Her husband, who would be the primary caregiver, was overwhelmed and confessed he was afraid of making a mistake, particularly with a new drug. My task was to create a personalized, low-stress education plan that would empower the husband to confidently administer the 5 new medications and provide safe, effective personal care, ensuring his learning was confirmed before discharge. My action followed 3 steps: preparation, demonstration, and confirmation. First, I organized all his medication into a labeled, color-coded weekly pill box and created a simplified, large print chart listing the drug name, dosage, time, and potential side effects. I then performed the demonstration using a step-by-step approach for both medication administration and safe bathing/dressing techniques, focusing on body mechanics. Crucially, I employed the teach-back method. After each step, I asked the husband, "Just to be sure I explain this clearly, can you show or tell me how you will give the anticoagulant dose tonight?" This allowed me to immediately correct misconceptions. For example, he initially planned to administer 1 pill instead of the 2 prescribed, ensuring critical information was retained correctly. The result was a palpable shift in the husband's anxiety from fear to confidence. He demonstrated 100% accuracy in the teach-back session for both the medication schedule and the personal care routine. I provided my direct contact number for the next 48 hours for immediate questions. This structured, personalized approach ensured a safe discharge, preventing readmission due to medication errors and securing the patient's successful transition back home.
Hospice often requires independent work in various settings. How do you prioritize and manage your caseload and scheduling?
I believe that effective caseload management in the independent hospice setting is a function of combining immediate clinical triage with meticulous logistical planning. I recall a recent situation during a high-demand period in community hospice where I was responsible for a diverse caseload of 12 patients scattered across a wide geographical area. One Monday morning, amidst a pre-planned schedule of routine pain assessments and dressing changes, I received an urgent call reporting that a patient, Mr. Jones, had experienced a sudden, breakthrough episode of severe, uncontrolled nausea and vomiting, requiring immediate attention. My immediate task was to swiftly triage Mr. Jones's acute symptoms to ensure his comfort, while simultaneously reprioritizing my remaining 11 scheduled visits to prevent delays for other vulnerable patients. My goal was to stabilize the acute patient and reschedule or delegate non-critical tasks sufficiently to maintain the high standard of responsive care expected in the hospice model. My action was to use a three-pronged approach focused on triage, communication, and geography. First, I performed an immediate phone triage with Mr. Jones's caregiver, coaching them through supportive comfort measures while securing a direct medication order from the physician. Second, I assessed my remaining visits, categorizing them by clinical urgency, e.g., for antibiotic administration took precedence over routine social support check-ins. I used my mapping software to dynamically reroute my travel plan, clustering my visits geographically to minimize driving time. Crucially, I contacted the two lowest acuity patients who would be delayed by 1 hour, offering transparent communication about the emergency and managing their expectations proactively. The result was that Mr. Jones's symptoms were successfully managed, and his goal of remaining comfortably at home was preserved, avoiding an unnecessary hospital visit. Despite the significant disruption, I was able to complete all critical and high-priority visits that day without compromising patient safety or satisfaction. This process demonstrated my ability to independently apply clinical judgment to triage needs, coordinate team support, and use logistical efficiency to manage a demanding, unpredictable community schedule.
What qualities do you believe are essential for a successful hospice nurse, and why are you a good fit?
I believe the three most essential qualities for a successful hospice nurse are empathic presence, clinical foresight, and resilience. These traits, when combined, allow a nurse to provide exceptional palliative care in often independent settings. First, empathic presence is vital. It's the ability to sit with a patient and family in moments of distress or silence, validating their experience without trying to rush or fix it. In hospice, the patient's emotional and spiritual pain is as critical as their physical symptoms. This presence fosters the trust necessary to have difficult conversations, such as those about goals of care or changing treatment priorities. Second, clinical foresight, the ability to proactively anticipate clinical needs and manage symptom trajectories. Unlike in acute care where you react to sudden deterioration, in hospice, you must predict complications like agitation, pain crises, or dyspnea before they become severe. This proactive skill is especially crucial in a home setting, where immediate support is often delayed. Third, resilience is necessary to navigate the emotional weight of caring for people at the end of life while working independently. It ensures the nurse maintains their own well-being to continue offering compassionate care without becoming burned out. I am a good fit for this role because my career history has focused on developing these exact qualities. My experience managing complex patient discharges demonstrates my clinical foresight in anticipating home care challenges and managing medications. Furthermore, the way I facilitate difficult conversations, like discussing advanced directives, shows my commitment to empathic presence and patient empowerment. I don't just see symptoms. I see a person's entire story, which is the foundation of high-quality hospice care.
What steps do you take when you encounter an unexpected complication or emergency in a patient's home?
The core of handling a sudden complication in the home setting is rapid triage, clear communication, and ensuring patient stability until higher-level care arrives. I encountered a critical situation while conducting a routine wellness visit on a newly discharged post-surgical patient. Within minutes of arriving, the patient became acutely short of breath, showing visible signs of distress and dropping oxygen saturation, indicating a potential pulmonary embolism or acute cardiac event. My immediate task was to initiate rapid emergency protocols to stabilize the patient, simultaneously coordinating external emergency services and providing clear, decisive interventions based on my current resources while mitigating further complications. My action was systematic and prioritized patient safety. First, I immediately positioned the patient in a high Fowler's position and applied supplementary oxygen from my emergency kit. Second, I quickly conducted a primary assessment, ABC, airway, breathing, circulation, recorded baseline vital signs, and delegated the task of calling the national emergency number, e.g. 999 or 911, to the family member present, providing them with precise information on the patient's condition and the exact address. Third, while waiting for the ambulance, I maintained continuous monitoring, administered ordered emergency rescue medication, as per protocol/standing order, and documented all interventions in the patient's response. Crucially, I maintained a calm, confident demeanor to manage the anxiety of both the patient and the family, providing reassurance while actively working. The result was that the rapid application of oxygen and the immediate administration of rescue medication stabilized the patient's saturation until the paramedic team arrived. I was able to provide a concise, high-quality verbal handover, including a detailed account of the patient's baseline status, the event timeline, and all interventions administered. My immediate, coordinated response ensured the patient was safely transferred to the hospital, where they received definitive treatment for an acute exacerbation, demonstrating that I can function decisively and effectively in an uncontrolled emergency environment.
Describe a time you went above and beyond to meet a patient or family's spiritual or cultural needs.
I faced a particularly delicate situation while caring for an elderly patient of the Hindu faith who was nearing the end of her life in an inpatient unit. Her family was extremely anxious because, according to their beliefs, it was highly important that the patient should not die on a bed frame, but rather gently placed on the floor to ensure a peaceful and proper spiritual transition. The hospital policy, however, strictly prohibited placing patients on the floor due to safety and hygiene regulations. My task was to honor the patient's critical cultural and spiritual need for a floor transition ritual while strictly adhering to the mandated safety and hygiene protocols of the facility. I had to quickly find an innovative, respectful solution that satisfied both the family and the institution. My action was to collaborate immediately with the charge nurse and the ethics committee. Rather than simply dismissing the request, I framed it as a necessary aspect of holistic, culturally competent care. Together, we identified an acceptable compromise. We moved the patient into a large, private room and placed a very low, specialized transfer mat on the floor. This mat was easily cleanable, protected the patient from cold, and provided a safe, cushioned surface, effectively meeting the family's spiritual need for the floor transition while maintaining infection control and fall prevention standards. I also ensured that the family had privacy for their final rituals and organized the hospital's spiritual care director to be present for support. The result was profoundly positive. The family's distress was relieved. They were incredibly grateful that the hospital respected their core spiritual values, and they achieved a sense of peace regarding their loved one's passing. This compromise allowed the patient to transition with dignity, validating the importance of her cultural background, and demonstrated my ability to advocate and innovate within regulatory boundaries to achieve truly patient-centered care.
Hospice work can be emotionally draining. What are your personal strategies for preventing burnout and compassion fatigue?
The question addresses the absolute necessity of self-care in hospice, a commitment I take very seriously, recognizing that I cannot pour from an empty cup. I rely on a conscious three-part strategy to ensure I maintain my effectiveness and prevent burnout, which includes compartmentalization, active debriefing, and physical health practices. First, compartmentalization and ritual closure are essential. When leaving a patient's home or ending a shift, I perform a deliberate mental ritual to transition out of the clinical space. This might involve a 3-minute quiet drive where I mentally review the day's successes and challenges, ensuring the emotional weight of a difficult case does not follow me into my personal life. This intentional separation prevents compassion fatigue from building up over time. Second, I prioritize active and scheduled debriefing. I utilize formal channels like my team's peer support groups, but also rely on informal, scheduled time with trusted colleagues to discuss emotionally taxing cases. This isn't just venting. It's a critical process of processing trauma and ethical dilemmas under the hospice umbrella. For instance, after a patient transition, I ensure I touch base with a supervisor or social worker to check in on my own emotional response. Third, dedicated physical health practices anchor my resilience. I commit to 20 minutes of movement daily, whether it's a brisk walk or a short session of yoga, which is non-negotiable for managing stress hormones. Furthermore, I ensure I use all my allocated time off. This comprehensive, proactive approach allows me to remain fully present, empathetic, and clinically sharp for every patient encounter, demonstrating that I view self-care as a clinical competency, not a luxury.
How do you process and cope with the grief you experience after a patient passes away?
Coping with grief is an inherent part of hospice nursing, and I view processing these losses not as a weakness, but as a professional obligation to ensure I remain empathetic and effective for my other patients. I recently cared for a young adult patient, age 32, with a progressive neurological condition. I had been her primary nurse for several months, and her death was deeply felt by our entire team due to her vibrant personality and the complexity of her family situation. Her passing left me feeling a profound sense of sadness and emotional fatigue. My task was to honor the attachment I had formed with the patient and her family while ensuring I professionally processed the loss through established support channels, preventing that personal grief from impacting the quality of care for my remaining, still living patients. My action involved a three-step process of professional and personal acknowledgement. First, immediately after the transition, I completed the necessary post-mortem care with immense respect, which served as a final act of service and closure. Second, I engaged in active debriefing. I scheduled time with my hospice team's social worker and attended our unit's bereavement rounds later that week. I used these formal channels to articulate the specific emotions related to the case and gain objective perspective on the quality of care provided. Third, I have a personal ritual where I write a brief, private, non-clinical note acknowledging the patient's impact, which allows me to consciously compartmentalize the loss before leaving the work environment. The result of this structured approach was that I fully processed the loss without letting the grief become debilitating. By utilizing a hospice's established support systems and my own personal boundaries, I was able to transition seamlessly to the care of my other patients the next day with my empathy intact. This process ensures my resilience, allowing me to maintain the high level of compassionate presence that every patient deserves during their end-of-life journey. Why have you chosen to specialize in hospice or end-of-life care, and what do you find most rewarding about it? I chose to specialize in hospice and end-of-life care because I was consistently drawn to the profound significance of that final chapter of life during my time in acute care. In a hospital setting, the focus is almost always on curing or prolonging life, sometimes at the expense of a patient's comfort and dignity. I realized my true calling lay in shifting that focus from quantity of life to quality of life. I found that the greatest, most meaningful difference a nurse can make is often found in that final transition, ensuring a patient achieves their goals for comfort and peace, surrounded by those they love. The most rewarding aspect of hospice nursing is the opportunity to facilitate meaning and reconciliation, not just for the patient, but for the entire family unit. It is incredibly rewarding to witness the shift when a family moves from a state of denial or frantic anxiety to a place of acceptance and calm presence. This transition is usually catalyzed by excellent symptom management, which allows the emotional work to begin. Successfully managing a severe pain crisis or coaching a caregiver through the physical changes of the dying process so they can feel competent and connected to their loved one is deeply fulfilling. It's about being a guide at one of the most vulnerable points of life, ensuring that even in loss, there is immense dignity and comfort. My goal is to never miss an opportunity to enhance the precious remaining moments a patient has.
In your opinion, what is the single most important thing a hospice nurse provides to a dying patient?
In my opinion, the single most important thing a hospice nurse provides to a dying patient is anticipatory comfort and control. While pain management and technical skills are foundational, the ability to anticipate and manage a patient's physical and emotional distress before it becomes overwhelming is paramount. This goes beyond reactive symptom control. It is the skilled intervention that prevents a patient from suffering needlessly and allows them to maintain a sense of autonomy and dignity in their final days. The dying process is inherently unpredictable, and fear the unknown often causes more distress than the physical symptoms themselves. A successful hospice nurse uses their clinical expertise to look ahead, anticipating the trajectory of dyspnea, agitation, restlessness, or a change in consciousness, and putting interventions in place proactively. This proactive approach gives the patient control over their environment and their body, reducing anxiety for both the patient and the family. For example, Recognizing early signs of impending air hunger allows the nurse to initiate low-dose morphine and positional changes immediately, preventing a distressing respiratory crisis. This creates a psychological safety net. The patient knows that whatever comes next, their nurse has anticipated it and will manage it swiftly. In the end, providing this reliable, anticipatory comfort is what allows a patient to stop fighting symptoms and simply focus on the profound work of saying goodbye.